Good morning. Good morning. Thanks for being here today. To start off your day, we've got a great program planned and some wonderful providers here to talk with us. But before we get too far, if I can manage all the papers up here, I will. I will read you a reflection. This one is one of my favorites. It's called God's Eraser. A Sunday school teacher was using a chalkboard to illustrate the story of Jesus walking on water and calming the sea. She drew huge storm clouds spitting out lots of wind and rain. She told the children how frightened the disciples of Jesus were. Then she drew huge waves wildly rocking their little boat. Next, she created on the chalkboard a shoreline and put Jesus walking from there toward the disciples on the water. Then she replaced the storm clouds and all their havoc with bright moon and glowing stars. "Why do you think the storm went away and the water got calm?" she asked the children. One precocious child responded, "Because you erased them." God's presence in your life erases the storms brought to you by others and by yourself. When you feel God's presence, you are assured of all of the help He brings. Maybe I just needed that one today. And I hope you enjoyed it as well. A few things in front of you on your table. We have, of course, the green slip that you're familiar with. If you want a chance to win the door prize, we have a no and go bag and a little grocery bag, and then also a no and go glass cup. And we have the yellow slips looking for your feedback, as we always do, looking to make this a better session. We get positive feedback, but when we don't, we try to adjust and make it an even better session. Also, we have information on the next No and Go Friday, which is Friday, November 11th, and we'll have Dr. Jennifer Norton with us to talk about integrative health, and we'll also have both of our wellness coordinators here to talk with us. This topic of the session is to achieve your best self. And then finally, there's a sheet, an 8.5 by 11 sheet, and that talks about some of the products and services we have available in our women's health line at the health shop, which complements the conversation that we'll be having today with Dr. Pasiuk and Lisa. So with that, I will introduce our providers. I think many of you know them. They're familiar faces around our halls. But to be a little bit more formal about it, to make sure you know where they're coming from and their background, Dr. Joanne Pasiuk is a board-certified general surgeon. She's been here with us at the Fond du Lac Regional Clinic for about 3 years. She was trained at the University of Texas Medical Branch and completed her residency at the National Naval Medical Center. Her husband, Dr. Brett Pasiuk, also works here with us as a nephrologist. She's joined by Lisa Michels, and Lisa is a nurse practitioner at the Cancer Center who received her master's degree from Marian University. She cares for oncology and hematology patients, but she also has some advanced training in cancer genetics and is our genetic counselor for the system. So please join me in welcoming these ladies.
We're mic'd up already.
Oopsie. Do you guys hear me okay?
And me? Okay. So we're here to talk about the continuum of care for breast cancer patients at Agnesian. And where do we start? So we start, the front line is primary care, getting people in to be screened. So why do we screen? So breast cancer is the most commonly diagnosed cancer among women worldwide. And it's the second leading cause of cancer-related death in women in North America. Approximately 1 in 8 women will be diagnosed with breast cancer in their lifetime. And of those people diagnosed, 1 in 30 will eventually die from that cancer. So breast cancer incidence increases as people get older, and we've made a lot of progress in identifying risk factors and looking for genetic markers, but most of the time this is something that people don't know they have for a while before it makes itself plain. So the good news is we have made progress. In 1960, the 5-year survival rate for a woman being told that she had breast cancer was 63%. And in 2012, which is kind of our most recent data, that number is now 89%. It looks even better if we break it down by the stage. So the earlier we catch a cancer, the longer that people are going to live. So people who have a cancer that is confined to the breast, 99% of them are living in 5 years. For people whose cancer has traveled to their local lymph nodes, that number is 85%. And where we find a breast cancer that's already traveled to another organ, then that number drops to 26%. So this is why we're here talking about this, and this is why so much effort is placed into increasing awareness. So there's been a lot of controversy lately about the cancer screening guidelines for breast cancer. It used to be very easy. If you were over 40, then the guideline said 1 mammogram a year. But there's been a lot of research and population health studies, and so it's changed slightly. So before age 40, essentially there's no requirement for mammograms in an average risk population.
Unless you have a first-degree relative that was diagnosed with a breast cancer before the age of 50, because then you'd have to start screening 10 years earlier than the person who was diagnosed. So if your mom was diagnosed at 45, you really should start annually at 35.
And let's reiterate again, we're talking about screening. So this is no symptoms, no change in your breath, nothing going on annually at 40 onwards. The screening is required by mammogram. If you have any of those changes, then you're no longer in that screening population. As soon as anything is noted by you as a change in your breast that is concerning, you should be seen. And so that makes things a little bit different.
And the American Cancer Society, even though they have these guidelines out, they do say that any woman who wants to have a mammogram every year should have it covered by their insurance.
Okay, so let's move on. So the American Cancer Society also says we should know that the risks and benefits of screening. So mammography is not a perfect test, but it's the best test we have. So we do want to just touch on those risks and benefits, but the most important thing is that we get women screened, because we know we've made a change in survival by getting people out there. So it does occasionally miss a cancer. 1 in 1,000 women being screened by mammogram will have something missed. But that's also why those repeat exams are important. We catch things early. If we miss them on the first exam, we'll miss the next. And if there's any change in your breast, come in. We also make people worried. So a lot of the reason we talk about over-screening and why some of these guidelines have changed is that we do require extra imaging for a lot of women. So in 1,000 women screened, about 97 women under age 49 will be asked to come back for more imaging. Now that number drops. So as women get older and the breast cancer incidence increases, so 10 years later, only 86 women under age 59 are asked to come back for more imaging. And at 79, only 69 women are asked to come back. So our sensitivity of our mammograms increases as women get older. So, now we also have 3D mammograms.
So we are very fortunate to have 3D mammography available at Fond du Lac site, or it's called tomosynthesis. So what it's like is it's still a mammogram machine where you have the compression from the top and the sides, but what's different about it is it's kind of like a CAT scan, where the gantry in front of you, or the actual x-ray tube, will actually move like this, and as it's moving, it's taking sequential images through the breast that the radiologist then will reconstruct to make like a 3D image of the breast. And it actually cuts down on the recall risk, or the population that has to be recalled. And it is being covered by most insurances. Medicare covers it 100%, Cisco covers it 100%. But the good thing about it is that if you have an insurance that maybe won't cover it, they should still cover for annual mammograms, like a 2D. And we just, I think, are asking $60 copay, which I think is really worth it. So.
The other thing to sort of mention about that is that the 3D mammogram is much more sensitive for finding things in dense breasts. Mm-hmm. So a lot of the problem with mammography has been in dense breast tissue. That 2D image with breasts being squished together doesn't give you the best picture, and now when we can see the breast in slices, we get a better resolution of what might be there. So what that comes down to say is that to find one cancer, we still have to do a lot of mammograms. So, and that again depends on the age of the woman. So in younger women, we have to do 556 mammograms. So 556 women get mammograms, 1 of those will have breast cancer. But as you see, as the incidence of cancer rises as women get older, the number of mammograms we need to do also goes down. And so as it's not a perfect test, it's the best test we have, and really we got to go back to, we have made a difference in survival. So this is still something we need to promote. Okay, so risk factors for breast cancer. So let me start off by saying that none of these things has a direct causation. And it's not like saying smoking causes lung cancer. And with a lot of these things up here we can't do anything about. All the things in blue have to do with estrogen exposure. So women who got their period early or continued to cycle later and had late menopause, or those of us who didn't have children before we were 30, these are all things that are done and over with and we can't change. It just means that you have to be a little bit aware of your risks. Now, some of those things you can change. So there is an increased risk of breast cancer in women who drink more than 3 glasses of alcohol a week. But if you're those of us who like to have a glass of wine with dinner, there is other things you can do to modify your risk factors.
Why'd you look at me?
I was actually waiting for you to look at me. So there are some studies that show that increased multivitamin multivitamin with minerals will actually decrease your breast cancer by about the same factor as that increase in alcohol. So
I take 10.
Not being physically active is associated with higher risk of breast cancer. Being obese, especially after menopause, is a risk for breast cancer, and that has a little bit to do with cycling estrogens. So you have estrogen from fat tissue, and so the more fat tissue you have after menopause, the more estrogen you're being exposed to. So things we can think about, but a lot of this is a life balance. You have to make the decisions that are right for you. If you have a high risk of breast cancer in your family, some of these things may be things you can modify and do something about. So this picture is up here for people who may not have been subjected to this test. Those of us who are, it's essentially, this is the oh, I got an image. So this is our actual mammogram machine. This is where the breast gets smushed between the 2 layers in order to provide a picture.
Ours isn't cool pink all like that. I like the pink one.
And I think most people in this room look like they're probably aware of this. So then the question is, what happens to that picture after it's taken, or those pictures in the case of 3D? So this is where our radiologists come into play. So the mammogram is going to show something. So in this case, and I'm really glad there's a nice little circle there because I'd have a hard time picking it out of that, right? So this is where our radiologists come in, and they see a nodule. And so then they'll look at that nodule and grade their findings. So if it's just a nodule like that one, the likelihood is it's going to get a grade of 0, BI-RADS 0. So this is the breast imaging reporting and data system that they use after they read a mammogram. 0 means we don't have enough information, we need more imaging. So BI-RADS 0 would be that last mammogram. Normal is where there's a mammogram that they see absolutely nothing on, it all looks totally fine. BI-RADS 2 says normal, but it has something that looks very benign, not worrisome, but that is going to go in to be checked against things next year. BI-RADS 3 is where it's probably normal, but they'll give you a 3 if they think there's like a 2% risk of there being something there. So that puts people on either short interval follow-up, so we'll bring them back in 3 months or 6 months to check out another image to see if anything's changed. BI-RADS 4, well, there's a big difference between 3 and 4. 4 is they really think that tissue should be gotten to be able to make a decision about what something is. They think it looks concerning, and those people need a biopsy. Now, 90% of those people will be able to get a biopsy done without going to surgery per se. It can be done by the radiologist. 10% needs to come see me. And once it gets up to 5, then they're really worried. They are pretty much telling you that this needs to come out, and we'll find out what it is before we go that route. But that's a BI-RADS 5, and BI-RADS 6 we usually don't see on screening exams because we know already that it's a cancer. So we'll see this on follow-up exams for patients who already have cancer. So let's go back to that mammogram and the radiologist who's reading it. So on our equipment here, they have the ability to make that look bigger and be able to sort of get a better look at it. And then they're going to request more imaging. So most of the time...
Can I say something?
Sure.
So I'm just going to interject. So we talk about fatty versus like denser breast tissue. So as we age, our breast tissue should and hopefully starts to look more like this, which is that fatty. This is more glandular, and when we say that people have dense breasts, like if you would mammogram a 30-year-old, the whole breast could look like this, which you could see something like that could be really hidden in something that dense. So that's where the 3D really helps. Okay, so just to point it out to you guys.
So then we go on to the further imaging. So a very good diagnostic test is ultrasound. So that little nodule, looking on ultrasound, this particular one shows that this is a cyst. It's dark inside, there's some shadowing afterwards, but so further imaging shows cyst. So same size of nodule on ultrasound, this one is solid. So this here, you can see there's a different kind of texture on the inside. There's probably some blood flow. There's a different kind of shadowing. It's actually brighter behind there. So on this kind of test, the radiologist is likely going to recommend a biopsy by ultrasound. And so they can do that when they're in there, and they can actually put a needle in, to that area and sample that tissue. So there are other imaging modalities that you've probably heard about. So I'm going to just touch on this very briefly. So breast MRI, you may have heard about this, but it's a very sensitive test in the sense that it finds a lot of things. It finds, the vast majority of cancers it will find. It doesn't miss very many, but it finds a lot of other things that are not cancer. So it's not the greatest screening test. It also has the disadvantages of being pretty expensive. It also requires a longer amount of time. It requires people to be in a very tight space and face down, in our case for breast MRIs. But sometimes that's the best imaging, especially for younger women or women in very high-risk situation, to get a better idea of what's going on. So you may have heard about that, but we're going to move on.
Pre-surgical.
Or pre-surgical. So
If it
sometimes
is a lobular cancer.
we want to be able to see if,
sorry.
no, that's all right. We want to be able to see if that
There's more extensive, like if it's DCIS and they're thinking that maybe it's more extensive, it goes more in more directions of the breast, or it's multifocal, and an MRI may help there. Lobular breast cancer, which we'll get to later, can sometimes be in the other breast. So doing an MRI before surgery just to make sure the other breast is clear.
those would be reasons that we would be recommending MRI. So radiologists are really good at sorting out one thing from another. So these are all things that would probably get a BI-RADS 2. There's findings, but they're not bad. So these are all calcifications. This is calcification that's in a blood vessel, and that person probably has got blood vessels calcified elsewhere in their body. This is calcifications in a degenerating cyst, not a problem. These are what they call milk of calcium. So there's a lot of calcifications in the ductal system. So this, it's still calcium in the ducts, but it looks significantly different from the kind of calcium in the ducts that makes us worry about cancer. And these are calcifications in a degenerating fibroadenoma. So those are all going to get a BI-RADS 2, and that's another reason we're glad we have great radiologists. So these are the kind of calcifications, see how tiny they are, that are more concerning.
Can you see that?
No. I can see either. This, if you magnify them out, this is the same thing. So they're really tiny, they're kind of clustered, they're pleomorphic, they're different shapes. And so this is going to show, this is going to require a biopsy that isn't something we can see or feel. And so the patient is likely going to be recommended to have a stereotactic biopsy. And so this is done again by the radiologists. They use an imaging, this is kind of like a modified mammogram machine down here that allows them to use that to find the area of concern that isn't palpable or visible.
So stereotactic biopsy is best obviously for calcifications, because calcifications you really are not going to see on an ultrasound unless it's associated like with a large mass cancer, that you may see some calcifications within that mass. But typically we would use a stereotactic for, again, lesions and calcifications, but ultrasound guided biopsies are going to be just for masses, palpable or non-palpable. And it's probably more convenient for the patient because they can be comfortably laying back on a bed and have, it's just, as you can see by this position, it's such a fun. So,
But necessary.
exactly.
On occasion.
Right.
So what happens when they take that core needle is that tissue that's just within that needle gets sent to our pathologists. And they put it under the microscope, and then they decide what category that tissue belongs in. So we really got three categories. We got benign, concerning, and cancerous. And today, given that we're here to talk about breast cancer, we're going to kind of skip benign and concerning, and we're going to skip to cancerous. Okay? The anatomy of the breast is we got three main components here. We've got lobules, which are kind of the factories of milk production. We've got ductules, which are the transport pathways for that milk out to the nipple. And we've got lymphatics, which are kind of the drainage that all runs back into the lymph nodes. And so cancer can start in any of those sort of areas. Now, when we're doing these biopsies, what we want to do is catch cancers before they've gone anywhere. And so that's when our pathologists come back. They get tissue that looks like this, and this is what they're seeing. So in those ductules, they've got cancer cells that are staying in those ductules. So this is DCIS, or what we consider a stage 0 cancer. This is one of those very confusing things because we treat it like cancer even though it's a pre-cancer. We don't think it has the ability to go anywhere yet, but we still know that we have to treat it aggressively so that it can no longer progress. So the other thing we can find is that that cancer has progressed. So this is that original sort of pathology slide, and now it's breaking out of the tubule. So this is an invasive ductal cancer on this side. And if it starts in the lobules, then it's way back here, but again, it's breaking out.
Okay, so when we do testing on the actual tissue from the procedure, we look for hormone receptors, okay? So breast cancer cells can actually have no receptors. They can have receptors for estrogen. They can have receptors for progesterone. This is just kind of, you have a little pointer.
Yes,
Thank you. So this just shows you what happens is this cell here has these little receptors right here. The estrogen comes in and it sits in this receptor, which actually starts a chain reaction of cells duplicating like this. And that's how cancers can form in some women. Again, there could be estrogen receptors, progesterone receptors, and there's another one that we will talk about that's called HER2/neu, which is actually a human epithelial growth hormone that some women have. Women who have, everybody's heard of the triple negative breast cancers. If you don't have any of these receptors, that's triple negative. Those tend to be more aggressive in younger women and can be associated with a genetic mutation.
And can I interject for a second?
Yeah.
So normal breast tissue, as you can imagine, has receptors on it for estrogen and progesterone, because that's how the body signals that it's going to have to produce milk or not stop producing milk. And so what a normal breast tissue will have all of those receptors on it. They have ER receptors, estrogen, progesterone, and a very few number of that HER2/neu. All of those are on normal breast tissue. And as cancers kind of get worse, they kind of change and they become less normal. And so they morph. And so if we lose all of those receptors, we know that that cancer has changed to something we have no way of targeting. Sometimes that HER2/neu receptor actually gets amplified. And that actually used to be not a good thing, because that's a receptor, as Lisa pointed out, that tells it to grow.
It's like an accelerator on a car.
Right. It says grow more, grow more. But we now have a medicine that actually is able to target that. And so now it's not such a bad thing when it's an amplified HER2/neu cancer, because we have a way of latching on and being able to target those breast cancer cells.
And this is just an example of a stain. So when pathology is trying to stain to see if the tissue is positive for these receptors, you can see, oops, I'm so sorry.
It's easy to do, isn't it?
Okay. You can see if it stains brown, okay, then they can tell that it's an estrogen receptor. If it stains in this type of a pattern or these colors, they can tell it's progesterone. And again, different staining for HER2/neu. A lot of times those tests are sent out, and we get results like in 7 to 10 days on those.
So if it was all that background blue color and nothing lit up in brown, then we would say it's missing those receptors. The pathologist is the one looking at these things under the microscope and making that decision.
Right. Okay, so some of the considerations to think of before surgery. So the patient is by Dr. Pasiuk, and she's talking to her about what are we going to do? Are we going to do a lumpectomy, mastectomy? And then we start talking about personal history, family history, and we find out that maybe this gal has a sister that had breast cancer, a mom that had ovarian cancer, okay, maybe a grandma that had a breast cancer at 70. But the patient herself maybe is anywhere from, 30 to 80. Depending on her age and family history, she may actually meet criteria for genetic testing, okay? And the genetic testing will actually help us decide what would be the best surgery for her. About 10% of cancers that are diagnosed can be attached to a genetic mutation. So, other things to consider, again, we talked about that briefly, the triple negative, the HER2 positive, size of tumor, and then again, if there's any positive axillary nodes from the imaging biopsy, these are all things that may even make us wonder if this person should have neoadjuvant chemotherapy or chemotherapy that's done prior to surgery. So this back to the genetics, as you can see, most cancers are sporadic in nature. Like Dr. Pasiuk said, 1 in 8 women with no family history will develop a breast cancer in a lifetime. And even we see in this category here, familial breast cancer. So these are the ones, obviously, there's the family history, but we've done genetic testing and everything is negative. It just was more pronounced in that family. But here, the hereditary breast cancer is about 10%. Now, we know that BRCA1 and BRCA2 are the most prevalent, okay? So about 70% of the genetic testing that we do that's going to have a mutation, it's going to be the BRCA1 and BRCA2, which most people know about because of the whole Angelina Jolie, okay? These are women that will have a 50 to 80% lifetime risk of developing a breast cancer and about a 15 to 25% risk of developing an ovarian cancer. It's also associated with male breast cancer, prostate cancer, sometimes melanoma, sometimes pancreatic. So obviously you have a woman that has a BRCA1 or 2, definitely would probably want to consider the option of having both breasts removed. So that's where it would help Dr. Pasiuk and the patient to decide, hey, I am positive for this. If I have to have surgery for the cancer, maybe I should consider having, double mastectomy so I only have to have the one surgery. So again, I was trying to allude before to some of the criteria. So even women who have breast cancer that maybe are like 60, but they're hormone positive and they have a family history, but it's kind of remote, they probably will not meet criteria, okay? And why I say criteria is important is because most of these tests are $4,500 to $6,500, okay? And they test anywhere from about 30 to 60 different genes, okay? We know now that 30% of these mutations are in other genes, so not BRCA1 and 2 anymore. The majority of them are, but if we just do testing for BRCA1 and 2, we could be missing something. So I like to do, if we have time, complete panel tests, okay? So if a woman that has a breast cancer under 45, she meets criteria. Affected, over 50, but has family history, meets criteria. Triple negative, but they have to be 60 or younger to meet criteria. And again, like I said, could influence the type of surgery performed, and it could determine whether radiation would be recommended. Because if she decides to have her whole breast removed and does not have any lymph node involvement, she may not need radiation therapy. Whereas if she would have had a lumpectomy, she would need to have the radiation therapy. This is just an example. I know Joe was like, you get the hard stuff. It's actually just really easy. What I wanted to show you guys is if you go back to biology, anatomy 101 and all those classes, building blocks, proteins, amino acids that build up our DNA, they're all these different amino acids, okay? And what happens in some of these mutations is they switch out. So as you can see, the cytosine is here and the guanine is here. But here, the cytosine switched out and it should have been an adenine. That actually is a point mutation right at that spot. That could mean something, it may not mean something. That could just be a variant. We don't do anything with variant. So this could possibly be a mutation that we'd have to act on. This is just kind of an idea of deletion, duplication, inversion, is all again with those amino acids. So this amino acid was deleted, you see it's gone. These, the B and C together, got duplicated. Okay, these flip-flopped. So that just gives you an idea of all different mutations and how they can occur in the DNA. Kind of covered most of this already, so. Okay, a couple things to think about. With genetic testing, obviously here we're talking today about the woman that has breast cancer, we did testing on her. But things to think of is that there are people that may not be affected, okay, but may have a big family history of breast cancer that may actually want to have genetic testing, okay? And what people need to know, especially the ones that we're testing here, is that 50% chance, if they have children, that they could have the same mutation that I had, okay, if I had a mutation. And what we would do is going forward, we would test for that specific mutation. So I did a whole panel test, okay, on the lady who was diagnosed with breast cancer. We found she had, say, a CHEK2 mutation. And usually the mutation is going to be a series of letters and a series of numbers that's just delineating where in that DNA there was a duplication or something that happened with the amino acid. So when that child comes in, I shouldn't say child, they should be over 18, they come in and we do single site analysis. So we just do to a blood, send it to the lab, and ask for them to specifically look for just that one mutation. Okay? Considerably a lot cheaper. Okay? Talked about cost. Insurance is really getting a lot better with covering these tests In fact, what's really neat, we have some insurance companies that are actually affiliated with specific genetic companies. So that's a huge step. We also have legislation now, GINA, excuse me, which is the Genetic Information Non-Discrimination Act that came out in 2008 that prohibits discrimination for having a gene mutation for employment or medical health care coverage. So I always counsel my patients that genetic testing has a psychological component. Some people say knowledge is power, and if I knew I had that mutation, I would do something. Some people think ignorance is bliss, right? And if I didn't know, I wouldn't worry about it. And so these are all things that you just don't take lightly. So that's why a lot of the counseling sessions are like over an hour, because there's a lot to really talk about.
Okay. So once we get down to sort of the options for the patient, that we're sitting in an office and we say, okay, you have a breast cancer diagnosis, or and we'll talk here about DCIS in that initially. We talk about there are two main ways to treat breast cancer surgically. One of these is mastectomy. It's been around for a long time. It's just removing all of the breast tissue. So all the breast tissue you have on that affected side, we take out. This is a traditional mastectomy, and we'll talk about the other sort of variations later. Over time, we used to take the breast tissue, the axillary nodes, even the pectoralis muscle back historically, and that's what they called a radical mastectomy. We very, very rarely do that these days. Most of what we're talking about when we talk about mastectomies is a simple mastectomy, taking all the breast tissue and the fascia off of the pectoralis muscle. So that's one option. The other option, and that's basically, hopefully, surgery and done. There are some caveats to that. The other option is taking out the cancer itself and an amount of normal tissue around the cancer, optimally, and then having the patient undergo radiation therapy. So this altogether is called breast conservation therapy. You can't just do this and meet standard of care. So the vast majority of patients who have an expected life expectancy of 10 years, the data shows that if we just take out the cancer and the rim, that there's too high a risk of recurrence or metastasis later. And so this is a package deal. You get the lump out, and we do radiation therapy. Now, radiation therapy is a short amount of radiation, or light therapy, as the radiation oncologists often like to call it. That it's about 6 weeks, Monday through Friday, to get treatment to the whole breast. So they may hone in on that area where we took the tumor out of, but the whole breast is treated. And so these are the two options, and this is a very personal decision for women. And for years we have been saying that there's really no difference in your life expectancy no matter which of these two options you choose. And people make that decision for very personal reasons. Some people don't want to know that they have any breast tissue to worry about there whatsoever. They don't want a mammogram every year. They don't want that. Then the mastectomy is sort of better for them. Other women are not really ready to give up the cosmesis of having a breast. They want to keep their own tissue. They want less is more. Now, the most recent data that has come out has shown that there is actually a benefit in terms of longevity. So people live longer, but it's a very specific group of people. The people who have the smallest cancers found the earliest actually have an increased life expectancy if they do breast conservation therapy. So for years we've said, okay, if you take out all of this, you have the least chance of having any recurrence, and you have the same life expectancy as if we just take out a small amount of tissue. But, and this is one of those things that's come out within the last couple months, the smallest cancers found in women who were the youngest, who actually did BCT, seem to have the best outcomes. It's very small, but it's one of those things where this is still a very personal decision, and so everybody weighs it individually. Okay, so lumpectomy just a little brief idea of what we're doing when we do a lumpectomy. A lot of these things we're taking out are breast cancers we can't see, we can't feel. We know that they're there by the calcifications and that tiny little needle. So again, we need our radiologists to help us to localize those for our surgery. So the patient goes down into radiology again, and a long wire that literally sticks out of the breast is placed in there into that area of concern. And then we talk to the radiologist before doing the surgery, and they say, well, this is the little clip from the biopsy, but these are the whole areas that you're trying to get. So this piece here. So we take the patient to surgery, we make a little incision, we try to make it as cosmetically good for the patient as possible, and we take out the tissue that surrounds this. And the goal is to get the area the tumor is in and a bunch of normal tissue around it. And to be safe, we take that tissue and we send it down to radiology afterwards, and we want to see a nice normal rim of tissue behind it. And if we don't, the radiologist calls us back and says, you're a little close on your margins, and so we'll take a little bit more tissue before we close the patient up. So if you have a precancer, this is something that might not necessarily be required. But once we know that that cancer has spread outside of its normal anatomical barriers, we also want to make sure it hasn't spread anywhere else. And so we go back to the idea of the anatomy of the breast. All of the breast tissue drains through a network of lymphatics. And those lymphatics then they travel through a channel of lymph nodes in kind of a necklace-like orientation. The first, all of that fluid goes through one node, and then another node, and another node, and sort of up into the axilla. And those first couple nodes that it hits are considered sentinel nodes. So back when we used to take all of the breast tissue and all of the lymphatics, we would find that the person might have 29 lymph nodes and there would be only cancer in 2 of them, but now they've lost 29 lymph nodes. So what we do now is we put a little bit of radio tracers, a little very minor radioactive material into the breast, and a little blue dye. And we wait for it to channel through the normal channels, the normal lymphatics. And then we use a little handheld Geiger counter, find the area in the underarm, which lights up with the hottest little beep, make a small incision there, dissect down, and look for the blue lymph nodes. Now that's the best case scenario, when the node is blue and the node is hot, and we take that out. And that's our first sentinel node. And the goal when we do the surgery is to make sure that we get 90% of the radio tracer out of the underarm. And we say that we've got enough sentinel nodes. Ideally, we get 3 nodes when we check it, but sometimes all we get is that 1. It's all stuck in that first one. But we send that off to pathologists, and then they go through that again, cut it up under the microscope, and see if there's any breast cancer that's traveled to the lymph nodes.
I interject something.
Yes.
So we know, because we're always doing so much research with breast cancer, thank goodness, that doing complete axillary node dissections really did nothing for long-term survival in women as compared to the sentinel lymph node biopsy. So at least by doing this, we're still identifying that sentinel node is the messenger node that if it has a cancer in it, we may decide, do we need to go back and remove more lymph nodes? But we're not just going and doing all that, because women who had that done may have gotten that bad lymphadenopathy, okay, that edema that you may see in some women's arms, which now really you barely ever see that anymore because of procedures like that.
And as Lisa was saying, now sometimes if we take out 3 lymph nodes and all 3 of those lymph nodes have cancer, then we're going back to take out the rest of them. But we're not doing it to everybody. We're doing it selectively, and we're trying to hone our treatment for the patient.
Okay, so staging. So sometimes the patient will probably say to Dr. Pasiuk, so what stage am I? And sometimes she won't know because you won't have all the pathology back yet. And then they'll be recommended to come over to see us in medical oncology. And so staging is really done according to tumor size, if there's node involvement, and if there's any metastatic disease. So the size of the tumor, if it's, you can see down here.
Yeah.
Okay.
Put your slide. You can have a point.
So you can see down here, T1 would be 0 to 2 centimeters, T2, 2 to 5 centimeters, T3 is greater than 5 centimeters, okay? So then that correlates to the stages here. So if I had, say, a 1 centimeter tumor right here, T1, and I had no nodal involvement, okay, I would probably be a stage 1. These can also break out into like a stage 1A, 2B, okay? And that's, again, according to some of the different sizes and nodal involvement. Now, I'm just going to talk about oncotype, but I'm going to go back to mastectomy.
Just really quick.
Okay.
Here. Yeah.
There's just so much to talk about. But we were saying we could do 2 hours of this, so that's why we're trying to, and you know me, I like to talk.
Yeah, so sorry, I'm going to do my little surgery spiel, and then we're going to talk about more about how we adjuvantly treat this. So we were talking about taking, for a traditional mastectomy, we take all the skin and the breast tissue, and the person ends up with a very flat result cosmetically. A lot of times, especially in younger women, they want a mastectomy, but they don't want to deal with being flat on one side. We do an immediate reconstruction. So when we do that, we take out the breast tissue through a smaller hole in the skin. Usually there's a wider scar because I'm not good enough to get out all of this tissue back here through a hole this big, but it's close. And then we work with plastic surgeons and we reconstruct the patient on the table at that same surgery. So the most common and sort of the easiest way to do this is to put in a tissue expander, which becomes an implant. So that envelope of skin that's left behind, we put in a very flat plastic bag. It's actually, I think it's a silicone bag. And then we inflate it with saline to kind of the nicest shape we can get in surgery without putting too much tension on that incision line. And then over time, after that incision heals, they can actually add more saline and stretch the skin to get an implant reconstruction. The other option, and especially in women who decide that they just want to get things over with first, they're just going to go flat initially and they'll worry about reconstruction later. Sometimes those people have needed radiation before they come back for reconstruction. So oftentimes that's not good because skin doesn't stretch well after radiation. So then we use woman's own tissue to reconstruct the breast. So these are the two most common sort of muscle flap reconstructions. This one uses the tram muscle here, and basically there's an incision of skin and fat over the muscle that's cut out of the belly. So down here, your abdominoplasty kind of incision. And then that tissue is kind of tunneled underneath the skin and up into the deficit of tissue left by the mastectomy. And so then a neo-boob is kind of created right here using the woman's own tissue. So the advantages of this is, in this reconstruction specifically, a lot of times we don't need to use an implant to get a good cosmetic result. The other thing is this is going to shrink with you, gain weight. Both boobs are going to gain weight. And it's pretty much, you've got that one for life.
And it'll be softer. And you get a tummy tuck.
And you get a tummy tuck. So in other women, we use latissimus dorsiflap, which it takes this muscle here and swings it over. A lot of times, there's not as much fat in this area of our bodies, and so sometimes people will end up needing an implant anyway. Okay, so then I think we're back to you.
Okay. Yep. Okay, so we talked about some of this already, so we'll just kind of breeze through that. So again, we talked about what determines what we're going to do for treatment. So now we're over at the Cancer Center, and patients are meeting either with myself, Dr. Jones, or Dr. Lumber, and we sit down and we're like, okay, we're going to talk about size of tumor first. So size of tumor we talked about was, obviously if it's a very large tumor, or there's a lymph node involvement, or they're triple negative, or we know they may have the lymph node involvement even before surgery, we know we're going to be recommending chemotherapy, okay? And depending on the size and if it's HER2 positive or some other factors may even help us decide what treatment we're going to be using, because there's obviously some regimens that are a little more aggressive than other ones, okay? So for size of tumor, I don't want to jump ahead of myself, okay. So for size of tumor, we have this other gene test, not to be confused with what I do. This is actually looking at the genomics of the tissue itself, okay? So this is a test called Oncotype DX, and this is a 21 gene assay that now NCCN guidelines says we can recommend to women who have a tumor that's even over just 5 millimeters, okay? So pretty darn small tumor. But what this does is it looks at what would be the probability of this woman having a really great outcome from receiving chemotherapy. And then it's scored low, intermediate, and high, anywhere from 0 to 100. I don't even know why they do that. It should be 0 to 50. I've never seen anybody over than 46. But as you can surmise, 17 is the cutoff. So 0 to 17, we would say low risk, more than likely chemotherapy probably isn't needed. 18 to say 23, it's like, well, you could go either way. You know, if you had a woman that's like, there's no way I'm going to do it, you'd probably opt not to do it. If it's going to be over, say 23 and going up, more than likely chemotherapy is going to be recommended and would be very beneficial to you. And this is just an example of what it may look like. So say I had a score that came back here at like 7, okay? So as you can see, my like 10-year risk of developing a breast cancer, recurrence would be about 5%, okay? And what they look like, or what they look at, is if you received no treatment plus chemotherapy plus tamoxifen, or tamoxifen alone, okay? And then what they do is they grade it, like I said, so say somebody had a 30, right, and they're up here, as you can see, their risk of recurrence would be over 20%, and so chemotherapy would be more recommended. So this is just another instrument to help us sit down with the patient and say, these are discussions we can have, we did this other test, you know, and what we're finding now is women who maybe received treatment didn't have a very high number. And so did we really help them? And vice versa. Maybe we didn't treat them because their tumor was only 5 millimeters, but their score, if we would have tested them, was a 40. And maybe they would have benefited.
So can I interject?
Yeah.
So this is one of the most exciting things about treatment today, because this test is using data gathered from women who've had breast cancer over like the last 30, 40 years. And so we're comparing all of their tumors and the little things about the little genetic mutations in all of those different cancers to our patient today. And we look at their tumor and whose tumor was it like. And so this is where, you know, we hear all this stuff in the news about maybe we're over-treating breast cancer. This is how we're trying to stop that. We're trying to cone the best treatment that's the right for this individual patient, and we're being able to use genetics of that tumor to do it.
And that's actually one of the Taylor RX trial, that we're accruing information on these women for 20 years.
So if chemotherapy is recommended, we're going to put a port in. And that's kind of what the port looks like. It's where it sits. It goes underneath the skin so you can't see it. And that little tail there is a catheter that goes into the vein that allows chemotherapy to be delivered just by sticking someone up here. And so we don't have to find veins. We don't have to subject those veins to the toxic effects of the chemicals. We can skip that. We talked about that.
Yeah, we talked about that. So, of course, just a little bit, metastatic disease, obviously, the woman has a large mass came in. We're concerned because it compromises most of her breast. We start to think that she already had metastatic disease. So those are women that we would put through multiple screenings and tests, CAT scans, bone scans, to see if there's involvement. Sometimes women who are metastatic, we may not even give chemotherapy to. Okay, we may not do a mastectomy. We may not do breast. It may just go right away to like a palliative treatment. Maybe a radiation, if there's a bone metastases, maybe just hormone manipulation. So again, different things that we have to decide. And again, stage 4, metastatic breast cancer, stage 4, it's left the breast. It is now in another organ or body part. Bone, brain, liver, lung, okay? Those are non-curable, okay? Not curable, but we can treat them.
Okay, just do one more thing before because I think both of us did talk about tamoxifen.
Oh yeah.
So one of the things that we can do for anybody who still has those estrogen and progesterone receptors on their tumor is treat them with a therapy that is not chemotherapy but is endocrine therapy. And so tamoxifen is and there are several others, are drugs that work on those on cells that have those receptors. They act as an estrogen blocker in the breast. Tamoxifen in specific, and actually I'm going to let you talk about this more with patients than I do probably, but this is a very well-tolerated treatment.
Yeah, so tamoxifen has been around about 35 years, and in fact we talk about that research. It used to be that women would put on tamoxifen, we didn't have any other drugs, and they'd be on it for 5 years and that was it. Well, now we know, because women had been recurring, that we want them to be on it for 10 years, okay? So tamoxifen is for women who are postmenopausal or premenopausal, okay? But there's another medication that's called an aromatase inhibitor. Okay, so that's a different type of medication. It kind of acts the same, but in a different way, if I can say that. And that's for just postmenopausal women. Okay, it can't be used in premenopausal women. It tends to be a little bit more effective than tamoxifen in postmenopausal women. You take it typically for 5 years. Interestingly, over the last 6 months, more information coming out that we should be considering 10 years. So we can kind of see where this is going as far as the importance that we see with endocrine therapy. And in fact, postmenopausal women, they may actually get more bang out of their buck from endocrine therapy than chemo. And so it's very important.
And these are, you know, when we talk about one of that biggest risk factors, all of those things that fell into exposure to estrogen, that's what we're targeting here. So as we understand more about breast cancer, we're able to use what we learn against it. So tamoxifen it locks onto those estrogen receptors and it blocks them in the breast. Estrogen aromatase inhibitors stops the body from making estrogen even in fat cells. So even after those ovaries aren't working anymore, it stops the conversion of normal steroids that we all have into estrogen. And so that's how it decreases a woman's exposure to estrogen. And what it did, we know for sure, is that it's a 50% risk reduction for women who have ER/PR positive breast cancers in recurrence. So for a drug that's not chemo, there's a lot of bang for the buck there.
And ovaries, adrenal glands, liver, and our fat tissue all make estrogen. That's why if we're obese, more prevalence of breast cancer because we have more adipose tissue making more estrogen. So now the next thing I just want to briefly, because I do want to have some time for questions, is living beyond cancer or survivorship. So now we've taken the woman from diagnosis to surgery to treatment, whatever she needed. Now she's on endocrine therapy for the next 5 to 10 years. But now what? Okay, so now we have to try to transition this woman back into normal living because her life has been compromised at the cancer center and we've become that person's family, okay? And in fact, on last day of treatments, most of them are crying, because they've made such a connection to us. And now it's like we're letting, you're helping that child on a tricycle and you let them go now, right? And it's scary for them. And so we have to try to transition them back. And we know that the number of people living with cancer is growing, okay? Because we've gotten better at treating cancer, okay? So less fatalities. So according to the American College of Surgeons, 14.5 million will go to 19 million survivors by 2024. And of these, 380,000 are survivors of childhood and adolescent cancer. And about 68% of today's cancer survivors were diagnosed with cancer 5 or more years ago. So living with cancer refers to the experience of receiving the cancer diagnosis, going through treatment, and then during that time the patient again is going to undergo treatments, cancer therapies. We have social worker and we have a dietitian and we have pastoral care that can help patients actually through the actual treatment. So I'll kind of buzz through some of these. So now living beyond cancer, again, the post-treatment, the long-term survivorship. So while 2 out of 3 survivors say their lives return to normal, 1/3 report continuing physical, psychological, financial problems, okay? Some people can have long-term neuropathy from some of the chemotherapies. They can have pain from radiation burns, okay? So there's things, like I said, that we have to try to transition them back. So there is actually, and again, I'm going to kind of talk off the whim here because we're probably running out of time. We know that the American College of Surgeons and some of our credentialing facilities are moving towards this survivorship. People have to be given or provided a survivorship care plan, okay? So when these people are done with treatment, we have a nurse practitioner, Rebecca Luncher, who's not here today, so I'm speaking on her behalf, that will develop a plan of care through a website we have that will tell the patient, it's kind of a nice little packet of their general information, when they were diagnosed, what surgery they had, what the staging was, if they had chemo, what chemo was it, how many cycles, if they had radiation, how long, how much gray were they exposed to, they put on endocrine therapy. So a big, nice kind of a compilation of that. And what's nice is that most of these patients obviously don't remember half the stuff they went through, so it's nice for them to have. I think it's also nice for family members, because I know when I'm talking to family members and genetics, they're like, well, I don't remember what mom had, and now this is all there for the family to have going forward. That's actually an appointment that Rebecca sits down with the patient and reviews the care plan with them. These are services that we have available: art therapy, family planning. We have retreats that patients can go on. There's sleep referrals, physical therapy, occupational therapy, lymphedema consults, nutrition and diet support groups, behavioral health referrals, and now we're connected to the YMCA through the Live Strong program. So there's a lot of things that we can do to help these people. They're sent a questionnaire out in the mail, and it talks about cognitive problems, sexual problems, diet problems, sleep problems, and then that's what Rebecca uses too when she meets with them. These are the issues you're having, and we understand that, but we have to do something about these so that we can get you back into your life before cancer. So this has really become a big area, not just for us, but for cancer centers around the nation. So again, huge progress that we're making. So on that, we'd like to say thank you, and if there's any questions. As you can see, there is a
There's a
lot. And we probably cut half of it out. Well, we thank you very much for your time.
Thank you. If you could please pass your green slips to your right, Katie will pick those up. Thank you, ladies. Amazing, lots of information. But isn't it great to know what resources we have here at Agnesian HealthCare to help patients and our family and friends?
Lisa or Dr. Pasiuk have a picture on video for us when it comes time?
Okay, I'll do it. She's gonna go.
Okay.
Thank you.
Also, just a reminder that we are in the middle of our Foundation Annual Appeal and our United Way campaign, so if you haven't already started thinking about your baskets for the basket raffle, that's something you can occupy your mind with. That drawing or the raffle will be on Thursday, November 10th at 1 o'clock down here in Creekside Cafe. So we'll also be live streaming that this year again, so if you're not on site, you can still participate in that. All right, drum roll.
I can't read it here. Carla Schomer.
Carla, in the back.
Yay, Carla.
Excellent. Thank you.